where she also has an appointment in the Division of Hematology. Her practice, research, and publications pertain to reproductive issues among women with blood disorders. She is involved both nationally and internationally in activities to improve health care for women with bleeding and clotting disorders. She is currently president of the Foundation for Women with Girls with Blood Disorders and also serves on the Medical Advisory Committee of the Platelet Disorder Support Association and the Medical and Scientific Advisory Board of the National Blood Clot Alliance. She previously has served on the Board of Directors of the Hemostasis and Thrombosis Research Society, as a chair of the Women's Issues Scientific Subcommittee of the International Society on Hemostasis and Thrombosis, and on the Medical and Scientific Advisory Committee of the National Hemophilia Foundation. During 2011 to 2012, she was a special advisor to the director of the Division of Blood Diseases and Resources at the National Heart, Lung, and Blood Institute at NIH. I have personally had the pleasure to work with her on CDC projects studying issues related to women and bleeding disorders. Dr. James joins us today to provide us an update on reproductive issues in women with bleeding disorders. Dr. James, welcome, and please begin.
Thank you very much, Vanessa, and I'd like to welcome our audience today, and I'd like to thank the CDC for making this webinar possible. As Vanessa said, we're going to talk about reproductive issues in women with bleeding disorders. I hope you'll be following along with me. I have a few disclosures relevant to the topic. I receive research funding, honoraria, or consulting fees from the companies listed on the disclosure slide. These companies manufacture plasma-derived von Willebrand factor, recombinant von Willebrand factor, recombinant factor 8, recombinant factor 9, or desmopressin. I've received funding from CSL Behring and Baxter in the last year and the other companies in the recent past. So our first slide, why women and girls? Well, women and girls are rarely affected by severe hemophilia. They are equally likely to have other bleeding disorders, including von Willebrand disease, and when they do, they are disproportionately affected due to the bleeding challenges of menstruation, miscarriage, and childbirth. And we've learned a great deal about bleeding disorders in women in the last 25 years. So the next slide you should be looking at is types of bleeding disorders in the female UDC. So what type of bleeding disorders do women and girls manifest? Well, actually, much of our data on the epidemiology, clinical presentation, and management of women and girls with bleeding disorders has been aided by the Division of Blood Disorders at the CDC. These are data from the Female Uniform Data Collection, or UDC, project, which was carried out at hemophilia treatment centers, perhaps yours. Some of you may have participated. From the female UDC, we have learned that the VWD is the most common bleeding disorder that causes women and girls to seek treatment, followed by factor 8 deficiency or hemophilia carriage. You will see that these numbers do not add up to 100%, and this is because some of the women and girls had more than one diagnosed bleeding disorder. The data we do have predominantly pertain to inherited bleeding disorders. Unfortunately, we have almost no data about the bleeding that women and girls with acquired disorders have, such as ITP or bone marrow failure. The next slide is the prevalence of bleeding symptoms in VWD, or von Willebrand disease. From a compilation of studies, we have learned that the most common bleeding symptom in females with von Willebrand disease is menorrhagia, or heavy menstrual bleeding, ranging anywhere from 32 to 100%, depending on the series. In the best studies, it ranges from 80 to 90%. And the next slide summarizes the content of a joint committee opinion from the American College of Obstetricians and Gynecologists and the American Academy of Pediatricians. So if we're going to talk about heavy menstrual bleeding, we first have to establish what normal menstrual bleeding is. Well, there is consensus that normal menstruation should begin between the ages of 11 and 14 years, that the interval from the start of one period to the start of another should be 21 to 45 days, and a period should last no more than 7 days. And a young woman should use no more than 6 pads or tampons per day. The next slide is the prevalence of menorrhagia in women with bleeding disorders. So we know less about the prevalence of heavy menstrual bleeding in bleeding disorders other than von Willebrand disease, but there are some data. Based on several different studies, we know that the prevalence of heavy menstrual bleeding is between 51 to 98% in severe inherited bleeding disorders, 59% in one series of patients with factor 11 deficiency, 10 to 57% in hemophilia carriers, and 35 to 70% in rare factor deficiencies. That should be 51 to 98% in severe platelet disorders. Excuse me. The next slide examines the causes of heavy menstrual bleeding by age. Those of us who work with women with bleeding disorders are somewhat blinded to the fact that not all heavy menstrual bleeding is due to an underlying bleeding disorder. In fact, most heavy menstrual bleeding is not due to an underlying bleeding disorder. But the cause of heavy menstrual bleeding varies by age. And the proportion due to an underlying bleeding disorder might vary by age, such that a greater proportion of heavy menstrual bleeding may be due to a bleeding disorder in adolescence. And this probably doesn't come as a surprise to you. Furthermore, the presence of one of these other conditions does not exclude a bleeding disorder. Sometimes we obstetrician gynecologists are guilty of finding one explanation and not looking further. In fact, one of these other conditions may unmask a bleeding disorder. For instance, anovulation in the adolescent or perimenopausal female may unmask an underlying bleeding disorder. Now, the next slide is the palm coin classification of abnormal uterine bleeding. This was established by the International Federation of Gynecologists and Obstetricians and is the system to classify abnormal uterine bleeding. As you can see from the first 4 conditions listed on the slide, polyps, adenomyosis, fibroids, malignancy, and hyperplasia, that they are abnormalities of the cavity of the uterus. The 5th, or coagulopathy, or an underlying bleeding disorder, is the subject of this talk. The next, ovulatory dysfunction or anovulation, is something I'll spend a minute or two on because it helps explain why we see more heavy menstrual bleeding in our adolescents and perimenopausal women. And listed below that is the category endometrial, which is a generic abnormality of the category of the uterus. And below that is iatrogenic, which I believe is primarily hormonal misadventures, prescribing too much estrogen or at the wrong time or et cetera. So in summary, a simplification of this system or classification for our purpose would be, number 1, abnormalities of the cavity of the uterus, 2, hormonal misadventures, 3, anovulation, and 4, a bleeding disorder. So the next slide is a cartoon of the menstrual cycle, the normal menstrual cycle, and I'm going to use it to explain anovulation. I don't have a pointer that I can use for you, but the upper half illustrates what is happening in the ovary, and the lower half illustrates what is simultaneously happening to the lining of the uterus. Now, first, let's talk about the normal menstrual cycle. At the beginning of a normal cycle, see the far left, in the lower half, the lining of the uterus is shed. Then, in the upper half, as a follicle in the ovary matures, it secretes estrogen and the lining of the uterus begins to build up. After the follicle ruptures and ovulation occurs, the residual or leftover sac forms the corpus luteum, which secretes progesterone. Now, progesterone matures the lining of the uterus, and if pregnancy does not occur, the corpus luteum involutes or shrivels, and the lining of the uterus is shed in an organized way. Now, let's talk about what happens in anovulation, meaning lack of ovulation, which is more likely to happen at the beginning and end of reproductive life. In other words, it's in adolescence or in perimenopausal females. So if there is failure to ovulate after the lining of the uterus is shed in that subsequent cycle, a follicle in the ovary matures, the lining of the uterus begins to build, but without ovulation, the lining continues to build and build and build until it becomes unstable. Then it is shed irregularly. And when ovulation finally does occur and the progesterone finally matures the lining of the uterus, the lining is very thick and large, and the period will be very heavy. And this will be true whether a woman has an underlying bleeding disorder or not. You can imagine if she has an underlying bleeding disorder, the bleeding could be even more extreme. But a woman who has anovulatory cycles, where she's ovulating intermittently and this lining is building up thickly, she is going to have very heavy cycles whether she has an underlying bleeding disorder or not. The next slide is just an example of a uterine abnormality. In this case, it's fibroids. But you can imagine if there were polyps, sustained overgrowth of the lining of the uterus, such as hyperplasia or cancer, that would provide an explanation for heavy menstrual bleeding as well. So on the following slide, we talk about the prevalence of bleeding disorders in women with menorrhagia or heavy menstrual bleeding. So what we have also learned in the past 2 decades is that not only are women with bleeding disorders more likely to have heavy menstrual bleeding, but women with heavy menstrual bleeding are more likely to have underlying bleeding disorders. So from a compilation of studies, we have learned that approximately 5 to 20% of women with heavy menstrual bleeding who have not previously been diagnosed with a bleeding disorder have von Willebrand disease. Anywhere from less than 1 to many as 47%, depending on how it has been defined, have a platelet disorder, and anywhere from less than 1 to up to 4% have factor XI deficiency. Less than 1 to up to 4% have hemophilia carriage, and less than 1% have rare factor deficiencies. Now there are, in the next slide, we have some data from adolescents. Now there are fewer data in adolescents than adults. There have been fewer studies. But young women with heavy menstrual bleeding are more likely to have an underlying bleeding disorder than adults. And from a compilation of studies, we have learned that approximately 5 to 36% of young women with heavy menstrual bleeding who have not previously been diagnosed with a bleeding disorder have von Willebrand disease. 2 to 44%, depending on how it's been defined, have a platelet disorder. Less than 1 to up to 4% have a factor XI deficiency. 8% have low factor VIII, and 13 to 20% have thrombocytopenia. Now, how should women and girls with heavy menstrual bleeding be screened for an underlying bleeding disorder? On the next slide, you see an illegible screening form, which can be downloaded from the CDC website. Actually, by the time a patient is formally referred to a hemophilia treatment center or hematologist for evaluation for a bleeding disorder, the patient has been, quote, screened, unquote, by someone, and the patient needs a diagnostic evaluation. But how about the obstetrician gynecologist, midwives, nurse practitioners, physician assistants, family practitioners, pediatricians, and internists who are trying to decide if a woman or a girl needs a diagnostic evaluation? Well, the CDC has developed a screening tool based on research led by Dr. Claire Phillip and sponsored by the CDC that shed some light on which women and girls with heavy menstrual bleeding should be investigated further. The research involved a study of 146 women with heavy menstrual bleeding who underwent comprehensive hemostatic testing and a 12-page battery of questions that might help predict a bleeding disorder. And on the next slide, there's a summary on how to use the screening tool. Distilled, there are 8 questions in 4 categories that predicted abnormal hemostatic testing in women with heavy menstrual bleeding. And the screening tool is considered positive if the duration of menses was greater than or equal to 7 days and the woman reported either flooding or bleeding through a pad or tampon in 2 hours or less with most periods, had a history of treatment of anemia, and I can add transfusion, a family history of a diagnosed bleeding disorder, or a history of excessive bleeding with tooth extraction, delivery, or miscarriage or surgery. Therefore, if a woman or young woman has heavy menstrual bleeding and a positive screening tool, she should be investigated for an underlying bleeding disorder. On the next slide is the laboratory assessment for the workup for a bleeding disorder. Women and girls who screen positive or are referred to a hematologist or hemophilia treatment center for a diagnostic workup should receive a history, physical assessment, and laboratory assessment. The initial laboratory assessment would include a complete blood count, a prothrombin time, activated partial thromboplastin time, von Willebrand panel, platelet function studies, other clotting factor tests, and other non-hematologic tests, including perhaps tests of thyroid function. So what about treatment? On the next slide, we see how 165 women in the female UDC were treated for heavy menstrual bleeding. I could do one whole talk on treatment of heavy menstrual bleeding, or maybe 2, but this is a nice summary slide on the treatments that were utilized by women in the female UDC. In women and girls, the most common symptom of a bleeding disorder is heavy menstrual bleeding. So many women and girls with a bleeding disorder seek treatment for the heavy menstrual bleeding. And as you can see in these data, there are 2 strategies. In tan are gynecologic strategies to reduce heavy menstrual bleeding. Oral contraceptives and levonorgestrel IUD are for women who plan more children, and endometrial ablation and uterine artery embolization are suitable for women who don't plan any more children and are an alternative to hysterectomy. In gray are hemostatic strategies to improve systemic coagulation. You can see desmopressin, antifibrinolytics, blood or plasma products, clotting factor products, and platelet transfusion. There was a nice study sponsored by the CDC that randomized women with nonspecific bleeding disorder to either desmopressin or tranexamic acid for the treatment of heavy menstrual bleeding. Both led to equal patient satisfaction, but actually the pictorial blood assessment scores were slightly better in the group that received tranexamic acid. On the next slide, we talk about other gynecologic bleeding in women with von Willebrand disease. While we have focused on heavy menstrual bleeding is not the only reproductive tract bleeding that women and girls with bleeding disorders experience. In fact, they are at risk for any reproductive tract bleeding. These are data from another study conducted by the CDC. Women with von Willebrand disease were compared with matched, unaffected controls. While it might not be obvious why women with von Willebrand disease would be at an increased risk of ovarian cysts, the most likely explanation is that the women with von Willebrand disease were more likely to have experienced hemorrhagic ovarian cysts. On the next slide, I have a picture of what happens during ovulation, which is normally not accompanied by any bleeding. But in a woman or a girl with a bleeding disorder, bleeding may take place into the abdominal cavity or peritoneum, into the broad ligament, i.e. the membranes that support the reproductive organs, or back into the follicle, creating a hemorrhagic ovarian cyst. And these can be prevented with combined hormonal contraceptives that prevent ovulation and can be treated with clotting factors. On the next slide, we have a summary of the conditions in the other bleeding disorders in which hemorrhagic ovarian cysts have been reported. They've been reported in 6.8% of women with von Willebrand disease, but have been reported in hemophilia carriage, afibrinogenemia, factor 10 deficiency, factor 13 deficiency, and platelet defects. On the next slide, we learn that endometriosis was more commonly reported in this same study in women with von Willebrand disease than in unaffected controls. On the slide after that, there's an illustration of endometriosis. It's a condition where the lining of the uterus grows in the abdominal cavity, but outside of the uterus. On the slide after that, there's some bullet points. The leading or prevailing theory is that endometriosis results from retrograde menstruation. In other words, menstruation that flows backwards out of the fallopian tubes into the abdominal cavity as opposed to out of the vagina. Retrograde menstruation is more likely with heavy menstrual bleeding, and heavy menstrual bleeding is more likely in women with bleeding disorders. And in the next slide, in the same study by the Centers for Disease Control, uterine cavity abnormalities such as fibroids, endometrial hyperplasia, and polyps were more likely to be reported by women with von Willebrand disease. Probably not because these conditions are more likely to develop in women with von Willebrand disease, but probably because these conditions result in bleeding that is more likely to become problematic in women with von Willebrand disease. And as a reminder, the next slide is an example of local pathology, i.e. fibroids, and you can imagine if a woman has an underlying bleeding disorder and has another abnormality, such as an abnormality of her uterus, she's more likely to have heavy menstrual bleeding. And then on the following slide, it was reported that among the women with von Willebrand disease, that they were more likely to have had a hysterectomy and have had it earlier in their lives than their unaffected counterparts. Now I'd like to shift focus and talk about pregnancy and childbirth. The next slide is bleeding with childbirth. Now, most bleeding at the time of childbirth is due to obstetrical bleeding. In other words, due to failure of the uterus to contract or due to retained placenta. It is less often surgical bleeding, in other words, due to incisions or lacerations. And it is sometimes due to a bleeding disorder. But most bleeding disorders at the time of delivery are very acute acquired bleeding disorders like disseminated intravascular coagulation resulting from excessive obstetrical bleeding or excessive surgical bleeding. Occasionally, bleeding at the time of childbirth is due to a pre-existing bleeding disorder like thrombocytopenia, platelet dysfunction, von Willebrand disease, hemophilia carriage, or rare bleeding disorders. And that's what I'm going to focus on. The next slide describes some of the changes in clotting factors during pregnancy. Women have evolved so that they are protected from the bleeding challenges of pregnancy, and such as miscarriage and childbirth. During the average pregnancy, coagulation factors such as von Willebrand factor and factor VIII increase, and the natural anticoagulant, protein S, decreases. On this next slide, you see some data from Dr. Jill Johnson's lab at the University of Washington, and they illustrate the increase in von Willebrand factor and factor VIII during pregnancy and the return to baseline in these clotting factors postpartum. But what we don't believe is that the increases in clotting factors in women with underlying bleeding disorders protect them from, to the same degree that women without bleeding disorders are protected. And the next few slides will illustrate that point. The next slide is reports of miscarriage in women with von Willebrand disease. Since women with bleeding disorders are at an increased risk of reproductive tract bleeding, it stands to reason that they may be at an increased risk of miscarriage. These are data from different series of women with von Willebrand disease, and you can see the wide range of rates of miscarriage, from 0 to 30%. But bear in mind that the background risk or rate for miscarriage for all women is 15%. So they may actually be in the normal range. On the next slide, you see data from different series of women with other bleeding disorders. And what clearly stands out in the highlighted studies, Locke and Burroughs, is that women with afibrinogenemia and women with factor 13 deficiency appear to be at a high rate of miscarriage. Both of these factors appear necessary for normal placental attachment and function, and in most cases of deficiency require supplementation during pregnancy. So during pregnancy and at the time of delivery, we have some population data that demonstrate that women with von Willebrand disease are at increased risk of peripartum bleeding. These data come from two different population studies, one in the United States and one in the United Kingdom. Bleeding during pregnancy, postpartum hemorrhage, severe postpartum hemorrhage, and perineal hematoma were all increased by a factor of 2 to 10-fold. Now, anecdotally, it seems that the greatest risk period is after the first 24 hours, but in the first 6 weeks after delivery. And we would call that a delayed postpartum hemorrhage. In the next slide, we have reports of delayed postpartum hemorrhage. The background risk of delayed postpartum hemorrhage is less than 1%. In most of these series, the rate was much higher than that, and certainly that's our clinical experience. These are small studies, but some reported a rate, for instance, in von Willebrand disease of 25%. What happens to von Willebrand factor and factor VIII levels postpartum in women with and without von Willebrand disease? Well, we recently finished an observational study to try to figure that out. One explanation for the increased risk of delayed postpartum hemorrhage is the rapid decline in these coagulation factors after delivery. In this multi-center observational study, using frequent serial levels, we documented rapid declines in coagulation factors in both women with and without von Willebrand disease. The von Willebrand factor and factor VIII levels in women with von Willebrand disease paralleled but were lower at every time point than those in women without von Willebrand disease. And in the next slide, we can see their modified pictorial blood assessment chart scores. In women the women without von Willebrand disease are in purple. The women with von Willebrand disease but who did not require treatment, in other words, in their last month their levels were greater than 50%, they're in tan. And in red are the women whose levels were below 50% going into the last month of pregnancy and did require treatment. In the women without von Willebrand disease and those who didn't require treatment, the bleeding scores declined exponentially. But in the women whose levels prior to delivery were less than 50% and required treatment, i.e. those in red, the bleeding scores despite treatment did not decline exponentially, suggesting, as we already knew, that they are probably at increased risk for delayed hemorrhage. They're also, in that group, their lowest hematocrits were 20% lower, and they had estimated blood loss at delivery that was 40% higher. The next slide is a very busy slide, and I don't expect you to be able to absorb all the detail, but I wanted to pick out a couple of details for you. In that same study of women with and without von Willebrand disease, out of the 32 women with von Willebrand disease who experienced 35 pregnancies, 15 women required treatment in 17 pregnancies. Half of the women who required treatment had type 1 von Willebrand disease, and the other half had type 2. You will see, if you can, that all but 2 of the women were treated with von Willebrand concentrate at the time of delivery, and those 2 were treated with desmopressin, and all but 1 received von Willebrand concentrate after delivery, and that one received nothing. Now look in the far column to the right. The range of treatment was anywhere postpartum from 0 to 21 days, and in the column before that, you can see that dosages varied and the range of dosages varied, so that we don't have good consensus on what the dose is that women should receive after delivery and for how long. But we do know they are at risk for bleeding for longer than we perhaps thought they were before. The next slide is entitled desmopressin, and I'd like to say a few words about it. And what I have here, I've taken from the National Hemophilia Foundation Medical and Scientific Advisory Committee Guideline number 192. Desmopressin can be used during pregnancy to raise von Willebrand factor or factor 8 levels prior to procedures. But it causes fluid retention and it can cause hyponatremia because it is synthetic vasopressin. United Kingdom guidelines recommend that fluids be restricted to 1,000 milliliters for 24 hours after administration. But since women at the time of delivery routinely receive 2 to 3 times that amount of fluid, routinely receive oxytocin, which causes fluid retention, and invariably undergo redistribution of their internal fluid from the extravascular space to the intravascular space after delivery, seems that at the time of delivery, desmopressin must be used with extreme caution, if at all. Now, we've got the baby delivered here. The next slide pertains to the fetus or newborn and how we should prepare for the potentially affected infant. The next slide are data from the UDC. 19% of bleeding in infants with hemophilia is head bleeding, and half of that is intracranial bleeding. The problem with intracranial bleeding is that 30% 6% of it results in neurologic damage, and 7% is lethal. So we'd like to prevent that. On the next slide, we talk about the risks of intracranial hemorrhage and the mode of delivery. The risk of intracranial bleeding in the newborn is actually a function of the mode of delivery. These are data from the UDC again, and we can thank the CDC for them. Out of 565 deliveries, the odds of intracranial hemorrhage were 8-fold higher with vaginal delivery. You can see for cesarean delivery, the risk of intracranial hemorrhage was 0.5%. And I should just say, for the sake of comparison, the background rate in unaffected babies is 0.05%. The next slide are the risks associated with operative vaginal delivery, meaning forceps or vacuum. So these are data from all babies, not just babies with hemophilia, but the purpose of including these data are to point out that the risk of intracranial hemorrhage is twice as high with operative vaginal delivery than it is with spontaneous vaginal delivery. So it may be 8 times higher with vaginal delivery than cesarean delivery, but it's even 2 times higher than that if the baby is subjected to forceps or vacuum. So as a consequence, the National Hemophilia Foundation developed perinatal guidelines regarding mode of the delivery for the potentially affected fetus. Obstetricians caring for women who are carriers of hemophilia should discuss the maternal and fetal risks of a vaginal delivery versus planned cesarean delivery. The option of a planned cesarean delivery should be recommended when an affected or potentially affected infant is anticipated. And in those women who elect vaginal delivery, forceps and vacuum extraction, interventions that double or triple the risk of intracranial hemorrhage in affected infants should be avoided, as should fetal scalp electrodes during labor. Now, women with severe bleeding disorders, including severe von Willebrand disease, almost always have an autosomal recessive condition and are not at risk of having an affected infant. The women who are at risk of having an affected infant are hemophilia carriers who are carrying a male infant, and that's to whom these guidelines apply. Consequently, the National Hemophilia has issued guidance for preconceptional counseling. On your next slide, those recommendations are summarized. Women who are at risk for being carriers of hemophilia should have their carrier status determined before they become pregnant. If factor levels are inconclusive, genetic mutation analysis should be done, and women and their families should be acquainted with the methods of diagnosing a potentially affected infant prior to delivery. They include pre-implantation genetic diagnosis, invasive prenatal diagnosis, IV chorionic villus sampling, amniocentesis and chordocentesis, and alternatively ultrasound determination of fetal gender. Before I part, I'd like to tell you about an additional resource besides the Center for Disease Control, and that's the Foundation for Women and Girls with Blood Disorders, whose mission is to see that every woman and girl with a blood disorder is correctly diagnosed and optimally treated. Our strategy is to educate the next generation of experts to care for women and girls with blood disorders. The website is womenandgirlsblood-disorders.org or fwgbd.org, and we have additional educational programs that are available to you free through the website, as well as the lending library and an Ask the Expert section. So in conclusion, women are rarely affected by severe hemophilia. They are equally likely to have other bleeding disorders, including von Willebrand disease. And when they do, they are disproportionately affected due to the bleeding challenges of menstruation, miscarriage, childbirth. Optimal care is provided by reproductive health care providers who understand bleeding disorders, and hematologists and hemostasis experts and their teams who understand the reproductive implications of bleeding disorders. Thank you very much for joining the call today, and we'll be taking questions shortly.
Yes, thank you, Dr. James, for such a great comprehensive presentation. Questions were actually solicited from those of you who registered before the webinar, and so we have time to take a few of those questions. So I'm going to go ahead and start with those questions that we did receive prior to today. So the first question, Dr. James, is can women with naturally low factor levels overclot during pregnancy?
Well, the answer is anybody can clot, because they may have naturally low factor levels in one area and have a decreased natural anticoagulant, decreased fibrinolytic factor, as part of their coagulation system. In other words, they may have other risk factors for clots that overcorrect or overcompensate for the clotting factor deficiency. We see this in our patients who have multiple other risk factors for clotting, and despite the fact they have von Willebrand disease, wind up having a clot. We also see it in the case of overtreatment. I hope that answered the question.
Thanks. And actually the next question is somewhat related, but the question is how common is clotting in pregnancy?
So 2 per 1,000 women have a blood clot in pregnancy. We would probably guess that women with an underlying bleeding disorder would have a lower risk, but we don't have good data on that.
Okay. The next question is related to treatment for bleeding disorders. So can birth control raise blood clotting factors and possibly hide an underlying bleeding disorder?
I think that historically we have thought that that was the case. In fact, most centers in the past wanted a woman off of any hormonal therapy in order to test her. Nowadays, the modern combined hormonal contraceptives contain a very low dose of estrogen that probably doesn't raise clotting, or raise estrogen levels much beyond what they can be in the natural cycle. So it wouldn't obscure a significant bleeding disorder. And the progestin-only contraceptives we don't think have any significant effect at all, or progestin therapy. So our recommendation is that women not be taken off of their hormonal treatments in order to be tested. And if someday, when they are not on hormones, they want to be retested again, if they tested in the normal range and they want to be retested again, fine. But if they test positive for a bleeding disorder, despite the hormonal therapy, we have our answer. If they don't, it probably wasn't a significant, they weren't going to be significantly altered by the hormones, and they can always be retested there later, but we wouldn't take somebody off of their hormones now to test them. I hope that answers the question.
Yes, no, thank you. And the last 2 questions are related to characteristics of women who may bleed or women with bleeding disorders. First, what is the average age of a diagnosis of a female bleeder?
Well, we don't have all the collected data in the United States. We can make some inferences from some studies. I know from a study we did here at Duke, we tested women who had previously been undiagnosed, who had heavy menstrual bleeding, and we limit it to women who are older than 18, and the average age of women who were diagnosed was age 38, okay? But we had excluded everybody under 18. Then we have studies in adolescents, and of course, they're all adolescent. One of our most informative studies was the female UDC, where the average age of women who were being either diagnosed and or treated was 26.5 years, which is probably a nice average.
And what about the average age of a woman who's receiving therapy for bleeding or receiving treatment? And that also may depend on, you discussed the different, whether it was more of a obstetric gynecological treatment like birth control and endometrial ablation, or whether or not it's a more hemostatic therapy. Perhaps there might be a difference because of that.
Yes, and we have individual studies, and they come from different populations, and they're not all alike. And the best answer I can give to that question is that